Good afternoon and welcome to the Columbus Metropolitan Club. We're streaming live from the Boathouse here at Confluence Park. And my name's Jane Scott. I serve as the president and CEO of the Columbus Metropolitan Club. And I'm just delighted to welcome you here on our live stream today. So thank you so much. Today's forum is part of our Optimal Health series and is presented by the Columbus Metropolitan Club, Nationwide Children's Hospital, and the Ohio State University Wexner Medical Center. Our Metropolitan Club live streaming is presented by the Emergency Response Fund of the Columbus Foundation in partnership with the Columbus Dispatch and PNC. We'd also like to thank all of you who purchased virtual seats to be with us today at the forum. It's been a large part of your support that has helped us keep the cameras on and keep the conversation going, so thank you very, very much. You can learn more about CMC, register for events, join or renew your dues, purchase a virtual seat, or make a donation anytime at columbusmetroclub.org. On to today's forum. COVID news changes daily, sometimes hourly, as we've learned more and more about vaccines, the virus, and the race to get shots in arms. While we should be maybe celebrating the amazing development of 3 effective vaccines, we also are aware that there are citizens with barriers to getting a vaccine and many others who are resistant to getting a shot at all. They present challenges to public health and herd immunity. And at the same time, the virus itself is changing, becoming more contagious, potentially more dangerous. The variables are many, and the future holds many questions. So let's listen to what our experts have to say. So let's please welcome the City of Columbus Health Commissioner Dr. Mysheika Roberts. Thank you, Dr. Roberts, for being here. Infectious Disease Specialist at OhioHealth, Dr. Joseph M. Gastaldo. Thank you. I guess Joe's over there. Vice President of Community Health and Wellbeing for Mount Carmel Health System, Brian Pierson. Chief Clinical Officer, Senior Associate Vice President for Health Services, Associate Professor for Clinical Internal Medicine at OSU Wexner Medical Center, Dr. Andrew Thomas. I knew I was going to do that. So thank you for being here, and I would be remiss if I didn't congratulate several of you for being mentioned by Columbus CEO as some of the top health professionals, so congratulations. And I'd like to welcome our host, the Interim Director of Professional Development at the John Glenn College of Public Affairs, Greg Moody. Greg, it's all yours.
Well, thank you, and thank you to our panelists and everyone joining us today. I want to remind everyone to please follow state guidance on wearing masks and social distancing. Here in the room, we have good ventilation. There are less than 10 people, and our panelists are sitting 12 feet apart. Thank you, everyone, for protecting yourself and others. 1 year ago this week, the first American died from COVID in a nursing facility in Washington State. The virus spread, and earlier this year took over as the #1 cause of death in the U.S. As a nation, COVID has so far claimed more than 500,000 lives. As a community, the CDC reports we lost 1 year of life expectancy to the disease, nearly 3 years for Black Americans, reversing a decade of progress made in closing the black-white gap in life expectancy. But hope grows as spring approaches. We now have 3 vaccines, and doses could be available for all adult Americans by the end of May. Last May, Dr. Roberts was here to discuss vaccines and health equity. And in November, we were right here in the room talking about the science of vaccines, what at the time promised to be remarkable effectiveness and safety. And every day we have more evidence that, in fact, that's true. For example, since December, when vaccines were prioritized in nursing facilities, new cases in those facilities are down by 80%, and deaths decreased by more than 65%. This turnaround is encouraging hope for what may be in store for the rest of the country. 2 months into one of the largest vaccination campaigns in history, 14% of Americans have received at least their first dose. However, those shots have not been equitably distributed. The differences have sparked a debate over why it's difficult to reach everyone who is eligible to be vaccinated. Are people hesitant? or do they not have access? That's what we'll explore today. Let's begin by taking stock of where we stand. Dr. Roberts, you and the Columbus Health Department have been on the front line of this issue from the beginning. How are you feeling about the COVID response in Central Ohio?
Well, good afternoon, and thanks so much for having me. I would be remiss by not also acknowledging that it was a year ago today that the Governor DeWine and Mayor Ginther announced that the Arnold would be changed. And so I know Dr. Thomas and I remember that day very well, but a lot has changed in a year. And if you had asked me a year ago whether I would think we'd be in a position like we are today to have 3 vaccines on the market, I probably would have told you no. In that year here in Ohio, we've had over 970,000 cases of COVID-19. We've had 17,000 individuals who have lost their lives, and we've had over 50,000 hospitalizations. If you bring that home right here to Franklin County, we've had about 120,000 cases of COVID-19. Of those, we've had about 1% have lost their lives, so 1,200 deaths, and about 3,000 or almost 4,000 hospitalizations. So a lot has changed in 12 months, but as you mentioned, Greg, we have hope. And so now we have vaccines. And so we're very optimistic about what the future holds, not only for us locally here in Franklin County, but across the state and across the nation. As we have 3 vaccine products now, and we've been pretty successful thus far in getting individuals in our community vaccinated. Just to put that in perspective, I can tell you for Columbus Public Health, we've had the vaccine since December, and we've provided about 45,000 vaccinations. And most importantly, we've fully vaccinated over 18,000 individuals. That means they've gotten their first and second doses. And then the other good news about all of this is only 2% of our patients thus far have been lost to follow-up for their second dose. So most people are getting both doses and getting the full protection from the 2 products that we had on the market prior to this week. So I'm feeling very good about where we're going. It's been a wonderful experience working along my hospital colleagues here in Franklin County, as well as Franklin County Public Health and Ohio Department of Health.
Great. So in terms of access, because it seems like we're at a tipping point where not enough vaccine supply, so we have people waiting, but we're entering a period where there may be supply. How do we assure delivery of the vaccine? So on that question of access, I know you're each incredibly involved in the community. Maybe say a little bit about what you're doing. Dr. Thomas, do you want to start the conversation?
Sure. Thank you so much, Greg. It's a pleasure to be here. Thanks for everyone for tuning in on this important subject. So at Ohio State, similar to what Dr. Roberts described, we received our vaccine in mid-December. In 1A, our role was vaccinating our own healthcare personnel. Moving into 1B in January, we moved from 3 sites within our medical center that were really good for employees but not great for patients. We realized that pretty early on and started planning a move to the Schottenstein Center, which is our basketball arena here on campus at Ohio State. So we opened there to the public on January 19th, and since that time, we've actually delivered for the total vaccine doses delivered in the concourse of the Schottenstein Center are 3 times the size of our seating capacity for the arena. It's just really an amazing effort. We've been doing over 2,000 a day and could do more with more vaccine supply. We're quite excited now. We've reached 42,000 total first doses and 28,000 total second doses, so 28,000 people completely vaccinated. We have had, for the most part, either Moderna or Pfizer up until this week. We got our first doses of J&J, which is a single-dose vaccine. We can talk about more a little bit later. Of note, we also opened our site at East Hospital last week. It's a site that's dedicated to the citizens that live in 11 zip codes that are mainly downtown, south of the city, the Near East Side, and Northeast Columbus. Actually, Dr. Roberts was very helpful in determining the right zip codes. There's zip codes mainly where patients may have less access to health care or less access to the vaccine, and we've been quite happy with the response of individuals signing up for that site for vaccination. We continue. In fact, we're doing vaccines there today and Friday this week, and then we'll be continuing that moving forward. So quite excited about the progress we've made and really what is a short time.
Well, Dr. Thomas, you mentioned the different phases and how the rollout happens. Dr. Roberts, I may ask you, where are we today? The folks who today are eligible for the vaccine, and where do you see that going over the next few weeks?
Sure. So right now, in terms of eligibility as of March 3rd here in Ohio, if you are in phase 1A or phase 1B, you are eligible for the vaccine. And what does that mean exactly? Phase 1A includes healthcare workers, so those would be individuals working in hospitals as well as non-hospital facilities, but individuals who are likely going to have contact with a potential COVID-19 patient. It also includes individuals who work and live in congregate settings, so that would include your long-term care facilities as well as treatment facilities and homeless shelters. Phase 1B is where we started introducing age, and so individuals who are over 65 are eligible for 1B. Also, individuals who work in K through 12 facilities or with K through 12 students are eligible. And then there's a list of medical conditions that are eligible in phase 1B, and they primarily include medical conditions that individuals were born with and are still dealing with or living with to this day. The governor did announce on Monday that he's opening up to phase 1C and phase 2, and so that's great news. That starts tomorrow, March the 4th. And phase 1C includes individuals who are pregnant, individuals with type 1 diabetes, individuals with ALS, and individuals who've received a bone marrow transplant, as well as individuals in the following occupations: law enforcement and corrections. Those are sworn officers only. It also includes individuals in daycare or child care providers, and it includes people, funeral homes, and then any firefighters that weren't included in the EMS rollout, which was included in 1A. And then phase 2 is individuals 60 and up. So that starts tomorrow, and all vaccine providers across the state of Ohio will be prepared to start vaccinating that group tomorrow.
And Dr. Gastaldo, I know you have some experience with the new vaccine. Is one better than another? And also in the Ohio health system, what is it you all are working on in terms of access?
So timetable-wise, first of all, good afternoon. Thank you for having me and this opportunity to talk to the Columbus Metropolitan Club. OhioHealth's timetable-wise is very similar, identical to Ohio State's as far as when we start vaccinating associates and when we start vaccinating those initially 80 and above. We are also obviously following the guidelines set out by the Ohio Department of Health on who qualifies. I do get a lot of emails and questions sent to me about the qualifications, so thank you for going through those. And it's it's a changing topic. I know the Governor DeWine has messages that come out and who's qualified, but I think for the public, it's something that I'm kind of excited to see, because I do see a lot of interest and motivated people in getting the vaccine and being vaccinated. That's good. More vaccines are coming, and before we were all started talking today, the three of us were talking, what is going to make a lot of this really go away is having more vaccines. And when you look at the timetable of vaccines coming out, more from Pfizer, more from Moderna. We have the J&J vaccine with 20 million doses being available the month of March. We have AstraZeneca and Novavax waiting in the wings. I was very happy to see the announcement from President Biden yesterday that tentatively by the end of May there'll be enough vaccines for all Americans. That's great. So a lot of the anxiety of people wanting to be vaccinated, that will go away as we get more vaccines. The J&J vaccine is a great vaccine. We now have a third powerful weapon in ending this pandemic. The J&J vaccine is different. It's a one-shot vaccine. It's something that is stored in the refrigerator. Operationally, it's much easier to get out. It works very similar to an mRNA vaccine. It teaches your cells to make the spike protein to develop an immune response to. The J&J vaccine performs like it should, and it performs in the same level as the mRNA vaccine. 100% of the people in the study that the FDA reviewed who got the vaccine provided 100% protection from dying and 100% protection from keeping people out of the hospital. That's what matters the most when you get a vaccine. At OhioHealth, we had our J&J vaccine delivered yesterday. We are trying to figure out how to use that vaccine to reach people who would be challenging to come back for a second dose, whether it be someone who's experiencing homelessness, someone who's not have a primary care physician. But that vaccine is really going to allow healthcare delivery systems to figure out how to get that vaccine out to people who have challenges coming back for a second dose.
That is encouraging. And you're leading into the conversation, too, is even the supply might be there. There could be systemic barriers, transportation barriers, things like that. How are you each, maybe if you want to finish that question, and then
So
Brian,
again,
I'm curious to hear about Mount Carmel.
that's a great topic to really start talking about now. Moving forward, in April, May, when we have more vaccines, there's going to be a point in time where there may be less uptake in getting vaccines. The people getting vaccinated now are very motivated, which is good. My concern is once we get to a point where we are having an open season for vaccines, we're going to start engaging people who have vaccine hesitancy. And now's the time to really take that vaccine safety and efficacy message to all communities. All communities need to hear that, and all communities need to have equal access to being vaccinated. COVID-19 has had disproportionate effects on different communities, the African American community, the Latino community. We need to acknowledge that, and there needs to be an effort to reach those communities who don't have access to this message and to the vaccines.
Great. Brian?
Yes, thank you. So what I'd love to do, some of the things that Mount Carmel have done, I think all the health systems are on a very similar timeline. So I'm going to focus a little bit more on things that we're doing with a community focus. First and foremost, collaboration is one of the things that we are recognizing as very important. And what I mean by that is on the 8th of March, this Monday, we're opening a collaborative clinic, vaccination clinic on our Franklinton campus with Lower Lights Christian Health Center. Our FQHCs have a lot of great knowledge. It gives us the opportunity to utilize shared resources, including human resources. One of the barriers that we anticipate seeing as vaccine becomes more available is simply having enough people to get vaccine in arms. So collaborating with other agencies is important. Further, we also recognize that we have an opportunity. I've read here just in the last couple of weeks some scholarly articles on the shadow pandemic. So we talk about the vaccination for the virus, and people are suffering from mental health disorders and addiction disorders, and we're seeing suicide rates increase, and we're seeing overdose deaths increase. We can't manage all those things simultaneously, but what we can do is use that 15 to 30 minutes that we have where people have received the vaccine and they can't go anywhere. We're monitoring them for side effects. We're going to use that opportunity in our collaborative partnerships to see who has a primary care relationship. If you have one and you haven't seen your primary care physician in the last year, we're going to see if we can get you back into your primary care physician. If you don't have a primary care relationship, we're going to see if we can't get you one. Hopefully, people will leave not just getting vaccinated, but also they'll leave with an appointment to their primary care physician. And primary care is a great place to start managing some of those issues that are co-occurring with COVID-19. In addition, we are planning, we have stood up, we've already registered all of our primary care offices to be able to distribute or provide vaccination. The struggle has been getting vaccination distributed to them. Most definitely, the Johnson & Johnson vaccine is going to open doors there. Further, as we look at community opportunities, we're working, again, collaboratively with public health and with the Community Shelter Board and another FQHC, Southeast Inc., to develop pop-up and mobile coach sites. So we're going to utilize our resources within our community health and well-being and street medicine programs to develop pop-up sites and sites that will be collaborative with agencies that are doing work that is similar to ours. We have 19 agencies already that have decided that they will partner with us. And what that does, the advantage to that is ensuring that we have the appropriate facilitator when we're reaching out to specific groups of people where trust might be an issue. There might be vaccine hesitancy. We want to make sure we have the right facilitator, that we're listening, and that we are not just coming in trying to be the experts. We want to hear what the real struggles are, and then utilize the experts within the community to help us understand how to get more vaccine into arms. So those are some of the things we're doing now.
Yeah, I appreciate you mentioning some of the other things that really have been signals for a while in the system that equal access might not be what we want it to be. And I think particularly for the Metropolitan Club, a number of kind of sessions really drawing attention to how COVID put a spotlight really on some issues that have been here with us for a while. I want to talk about vaccine hesitancy in a second, but still on that issue of really pushing to reach groups that maybe have systemically been excluded from easy access to the healthcare system. I'm curious just to hear a little bit more about specific things you're each doing to really overcome that particular barrier.
So I can say Columbus Public Health, we've been working with many of our community partners, and what we've been asking our community partners is reach out to your constituents, reach out to your members, and get them to come to our clinic to get vaccinated. What we found is a lot of individuals in our community, particularly the minority community, are almost intimidated by the system and the process to get registered to get vaccinated. So they need some help, some support, some guidance of where to go, how to do it. So we opened an opportunity clinic at the health department that is open to individuals who live in 16 of our most vulnerable zip codes here in the city of Columbus. These are the same neighborhoods that have high infant mortality rate, high unemployment rate, high crime, and low educational attainment. And we've identified agencies in those zip codes who can recruit their members, their customers to come to us. They call us on a special line that's just dedicated for them, and we can get them registered for an appointment to get the vaccine. If they have some mobility challenges, we ask them, mobility meaning walkability challenges, we ask them if they prefer to come to our drive-through clinic. Many people who walk with a walker or in a wheelchair prefer that method than to have to get out of their car, especially as the weather has been really cold lately. So we're making some concerted efforts, as Brian already mentioned, to work with our community partners to drive those individuals into our clinic or some vaccine clinic, to let them know that it's available and to inform them of how important it is for them to get vaccinated.
Well, and so many in the audience today are those community collaborative partners. So please do hear this message of anything you can do with your organization, with the people you serve, to really take advantage of these resources. Other examples in the space?
Sure, a couple things. We have a group that's been established as a part of our COVID Command Center on external engagement related to the vaccine. So Autumn Glover, Bethany Camp, and Dr. Darrell Gray are leading efforts in the area around East Hospital and then in the other zip codes, as I mentioned earlier, where we're working with local clergy, we're working with the YMCAs, YWCAs, attempting to get students actually out into community centers with laptops to help people schedule. We have a phone line, obviously, where anyone can call, not just established patients for the medical center. It's 614-688-VAX, V-A-X-X. That's available during business hours for scheduling. So we're trying to do our best to get out into the community, similar to our other partners, and partner with people that are in the community, since they know who may have difficult challenges with transportation or difficult challenges with just accessing the system, to do our best to help them.
OhioHealth also is trying to get creative and doing things. OhioHealth.com. I forget the phone number, Andy, but there is a phone number you can call if you go to OhioHealth.com. Anybody can get teed up to get scheduled that way or call a phone number. OhioHealth has repurposed our Health on Wheels. OhioHealth has a couple buses that they have used to provide health care that are being repurposed to give vaccines in the Hilltop community, for example. We have vaccine clinics on wheels that are going to different communities. So you and I were talking earlier before, we really have to use this as a time of creativity to lean in on technology, Uber, Lyft. How do we get vaccines into people's arms? And that's where I'm really excited to see what we do as a community to really come up with creative ways to deliver those vaccines to people who can't travel, people who don't have English as their first language, people who don't have a phone, people who don't have Wi-Fi access. We really have to get creative in getting those vaccines. COVID anywhere is a threat everywhere. And we really have to get into that mindset when it comes to how we really best serve our Central Ohio family.
Well, and taking some of those lessons learned, too, those strategies that really help people connect in terms of getting the vaccination, that's also true about primary care and other things that have disenfranchised individuals, that we can use some of those same strategies going forward. So it's encouraging that you're all talking about the supply basically catching up with where we are right now. But even if we address the access barriers and there's enough vaccine to go around, how do we address vaccine hesitancy? There's a lot of misinformation out there, but also some genuine concerns about safety or mistrust of the medical establishment, particularly in communities of color. How do we overcome these barriers?
I'll start off answering that because I do a lot of COVID Q&A vaccine things. You know, we have to acknowledge vaccine hesitancy, and we have to respectfully engage all people in a non-judgmental manner when it comes to vaccine hesitancy. You know, you may have a question that you are embarrassed to ask about, but it's important that you're heard, and it's important for you to get an answer from a reliable source. You know, throughout this whole pandemic, something that I've been dealing with a lot is what I call the infodemic, with a lot of misinformation related to COVID-19 that's really carried a lot over into the vaccination process. The vaccines that we have, the 3 powerful weapons we have, are safe. They are effective. Approximately 50 million Americans have received an mRNA vaccine, and there's been no serious safety signals that have popped up anywhere, even more so worldwide. We need to acknowledge vaccine hesitancy and really take this message in many ways that we can to all communities. And we really have to lean on business leaders, the medical field, those in the clergy, really anybody who is looked up to in their community to talk about vaccine hesitancy and really to engage people when they have questions. Your question may be different than somebody else's question, but getting your question answered is important to you so you can decide, hopefully, to get vaccinated. What's going to end the pandemic is rolling up your sleeve to get vaccinated.
Along those lines, what we've tried to do with town halls, both at the university-wide level and within the medical center, and we sometimes have 1,000 to 2,000 people on these town halls, is to kind of create an army of informed individuals that are trusted in their community. So people they go to church with, people whose kids play soccer with their kids, that whether they're a healthcare professional or an administrative assistant or a transporter or an environmental services individual, if we can educate them and they can educate people in their community, that's of value. I think we've all participated in a variety of public forums like this where we've done that. But I think when it comes from someone you trust, your minister, your local council, city council person, the person who runs the PTA at your kid's school, those are trusted voices, even more so than any of us standing up here at a session like this. So we're trying to make sure we create an army of educated people. But I think it's important to realize, even within our own healthcare fields, we have people that were hesitant in December to sign up. So it is a real thing, and it's something that more information, more education, and less judgment, I agree with you, Joe, is important. And to realize right now we are in, as you described, Greg, a very high demand, low supply. And the people that are in high demand are the most at risk. They're elderly patients, they're patients with high-risk medical conditions or high-risk occupations. A number of us have talked about this, and we foresee a time not too far from now, say June, July, where we will be in a very different situation. We will be in a high supply, suddenly low demand situation. So trying to figure out how we get 20-somethings, 30-somethings, and 40-somethings to want to get a vaccine, to take time off work, to do whatever. We have to make it easy for them. So we're working also with a group of employers, trying to make sure they're educating their employees about the benefits of being vaccinated.
I think I'd be, remiss if we didn't just acknowledge about the African American community and their mistrust for government and science, and it stems from, decades and years of mistreatment, not to mention this Tuskegee study, as well as Henrietta Lacks. And, as Dr. Gastaldo mentioned, you just have to acknowledge that it exists, that hesitancy exists and where it might come from, and then educate them of how things have changed as a result of those incidents that happened in the medical community so many years ago. But what I remind many minorities, and really anyone for that matter, is don't let past injustices get in the way of you protecting yourself and your loved ones today in 2021. Yes, things happened in the past that were wrong, should never have happened, and hopefully they will never happen again because of some of the many safety measures that have been put in place. But this vaccine is safe and effective. It was made for all Americans, all people around the world actually, and everyone who's eligible should roll up their sleeves and get vaccinated.
I agree with everything everybody has said. And one thing that I would add would be the education that we offer in specific communities needs to be timely. So as we have a program called a door-to-door program. So it was originally designed years ago to go door-to-door and vaccinate folks as part of our community outreach. As we reinvigorate that program, we're also going to be, in a timely fashion, several days or a few days prior to all of our scheduled door-to-doors, have an education session that will both be, give people the opportunity to be present in person as safely as possible and virtually. Again, that gives us hopefully the opportunity to gauge, increase interest and knowledge of the fact that it's happening, and the education that we provide will be timely so we get more people scheduled.
Yeah, that's great. I think at this point I'll mention that in a few minutes we'll move to questions from the audience to give folks a heads up on that. But before we do that, I guess the question I'd ask is all of these challenges you're describing, it requires collaboration at a community level. So what's some of your best advice for folks who are listening right now, who are in a position to take action either with their own employees or they're in an organization that's in a position of service to others? What's your best advice about how to really overcome some of the access and hesitancy barriers we've been talking about?
I'll start on
Joe?
that one. So
Yeah.
I think from a setting of hesitancy, I think now start the conversation. Start the conversation in a respectful, non-judgmental manner. Acknowledge that hesitancy out there. Most of it's rooted to misinformation that's out there, whether it be the vaccine, so-and-so says this about the vaccine induces infertility in women, the vaccine comes from this, the vaccine comes from that. You know, people hear that from unreliable sources, and then they use that to already decide whether or not they're going to get the vaccine from misinformation. So when people have that hesitancy, really say, hey, why aren't you going to get the vaccine? Let's talk about it. What have you heard? And really try to be a myth buster when it comes to the vaccine. And there are a lot of myths out there about the vaccine.
Yeah.
I think one thing that's been clear to me is there are a group of people that are, before this, we're already skeptical of vaccines. And I do think sometimes a number of us try to find ways to convince those individuals to change their beliefs. And that's probably not a good use of our time. To be honest, I think at this point, the best use of our time is taking people that just haven't thought much about this vaccine. You know, they might even get a flu shot every year, but they've never asked, what brand of flu shot are you giving me, doctor? Or what's the effectiveness of that? Now, suddenly, there's all these new issues in the press about percents of effectiveness and 2 doses and 1 dose. They've never had to weigh this kind of information before to make a decision about where to schedule, when to schedule. So trying to just to get that kind of middle group, that we clearly have a group of people that want to get it yesterday. We clearly have a group of people that may never get it, and that's fine. It's finding that group in the middle that we think we can influence. It is difficult to say it's incredibly important to be vaccinated, but you can't get it yet. That is a really hard message from a PR perspective, but I think building that case and building that understanding of when it's your turn, don't worry about what vaccine it is. They're all effective, they're all safe. Get whatever one you can get is probably the best messaging we can start with.
One thing I'd like to add too, so for those folks that are part of smaller agencies and you're wondering where you can participate, I would say even ask yourself, where can you lead? If you're an agency that has influence, positive influence over a population of folks that might have vaccine hesitancy, hospitals and public health, we're not always the right agencies to take the lead. Sometimes agencies that have a lot more trust with specific populations are a much better choice to take the lead. And you certainly call the hospitals and get public health involved, but don't be afraid to take a leadership role. You may be more successful in those spaces than we can be.
And the only thing that I would add is, you know, I appreciate the comments that were made about talking to your staff or talking to your colleagues, but I think we shouldn't make assumptions. I know for myself, I made a lot of assumptions that 1A, when they were eligible, they would all roll up their sleeves and get the vaccine, and we all learned about the hesitancy within the healthcare community. So we realized there's going to be hesitancy in the community. So, you know, as was said, talk to your staff, you know, figure out what they're thinking, what myths they have, invite an expert in to provide them with some factual information information. And I also think another thing that's a turnoff for many individuals is mandating it. I know legally that most lawyers have told me because FDA hasn't granted these vaccines full approval, you can't, as an employer, mandate it. But I would really discourage people from even talking that language or considering that. I would really try to educate them and explain to your staff, your colleagues, why they should get vaccinated versus this enforcement idea that it will be mandated or expected for them to get vaccinated.
Yeah, Joe.
One more thing, too, from like an incentive perspective. The first thing I want to say is our COVID positivity rates in the country are still too high. They are still too high. Our positivity rates are really where they were in middle to late October. They're still too high, and we still have to follow the recommendations that come out as far as mitigation practices, masks, all this other stuff. However, and I do want to emphasize the word however. Looking forward, as more and more people get vaccinated and we have more community immunity, I do see eventually there will be some guidelines put out for de-escalation of masks. So there may be a time in the future, I don't know when, where we're going to have recommendations that people who are fully vaccinated in a small group in private could be together without wearing a mask. That's where the hockey puck is moving. I do see that happening sometime, but the rate limiting step is community immunity from people rolling up their sleeves and getting the vaccine. So really, I think as a community, we all really have a civic responsibility to be part of that conversation and really roll up your sleeve to be vaccinated.
Yeah, Joe, I agree with you. I think the metric, if you think about the metric that the governor used to scale back the curfew, it was about patients in hospitals, and that was very legitimate to do. But I think when you think about masking guidelines and masking requirements, I don't think it's actually patients in the hospital or even cases being diagnosed that are the metric. I think it's really the percent of individuals that are vaccinated is probably going to be that risk mitigation that drives people to not have to do other mitigation. And that may happen sometime later this summer or later this fall. But if people don't sign up to get vaccinated, it's not going to happen anytime soon. We really need people to focus on the other positives, that if you've been vaccinated and then you're exposed to someone else, you may not need to quarantine. And of course, you may not get sick, which is really, really important to those around you who maybe haven't been vaccinated yet. So.
And I would add to that, does anybody here know anyone who's had the flu this year? I don't. So, certainly masking and distancing makes a difference.
We've had 0 positive flu cases at Ohio State so far this year in terms of even flu tests. And I believe the data I saw, less than 100 admissions for the flu in Ohio so far this flu season. And this time last year, it would have been around 7,000 or 8,000 flu admissions. So masks do work. I agree.
Positivity.
0 admissions at Riverside also, too.
Yeah,
But again,
our positivity rate's 0.032%. It's very low.
Yeah.
Well, and maybe this is the next forum where we've always had it within our power to eliminate flu. And yet there are practical considerations why we don't do that. And I think this conversation around kind of where we are right now, Joe, I liked your framing of this as kind of a community conversation we're all a part of. And not only in this moment, but I think really taking a look at what this has shown us about how the system functions, about who's included and not included, and really making sure we extend that conversation beyond just the vaccination. Hopefully within 5 or 6 months, everything you've described will have come to pass, and we really are now on to kind of that next phase of normal. But in the meantime, there continue to be a lot of questions. So I think in the spirit of that, it's probably a good time to turn to the audience and let the panel respond to some of your questions.
All right, we have a lot of questions. So some have been answered, and some people are asking kind of a follow-up question. So Erin McKee from OSU, the James, she said she was in the first 1A vaccine group because she is a healthcare worker, but her appointment was canceled. She has not been able to reschedule or get scheduled locally because she's not in the 1B group. So how do I get my vaccine? Because they keep on rolling in new people.
Sure, I can take that one since it's an Ohio State question and I was involved in that situation. Yeah, we actually made an unfortunate error in that when we had some 1As that scheduled right at the end of the eligibility period for 1A. We allowed some of them to schedule after a drop-dead date that the state had, which was January 23rd. And there were, unfortunately, about 1,500 individuals that had their appointments scheduled, but we were asked to stop doing those vaccinations. Now, those individuals, we've reassessed them based on the really tight definition the state has applied now for 1A. And a number of those people, in fact, 350 were invited for vaccination this week. We're allowed now to vaccinate up to 5% of our Pfizer and Moderna allocation per week. So that's about 350 individuals. So we're working through that list of people who had vaccinations canceled. We think over the next 4 to 6 weeks, we'll have all those individuals vaccinated.
And I can just add that Columbus Public Health is vaccinating 1A. That registration opened this morning. So if individuals want to sign up to get registered through Columbus Public Health, whether you're 1A, 1B, or 1C and 2, you can do that by calling 614-645-1519 or going to our website, columbus.gov/coronavirus.
And Lainey, I should have introduced you. Lainey Cuthbert, thank you for fielding the questions.
That's just fine, thank you. When the first vaccine formulas, this is from Richard Needles. When the first vaccine formulas were approved in November 2020, why were the national labs not engaged to go into production mode more quickly?
All I can say, I'll take that one. I don't think any of us have an answer.
After you, I'll take a stab.
Yeah, I don't think any of us have an answer about why a lot of things have happened during the course of the coronavirus pandemic, especially things we weren't directly involved in. But I will say the announcement yesterday of actually a partnership between 2 different competing drug companies to make one of those companies' vaccines is exactly the type of partnership that we need to really expand access and to really grow that capacity so that we get to a point, like I said, by this summer where we have a high supply and unfortunately maybe a low demand situation, but that's what's going to get us there more quickly. So it's those type of innovations that I think are the way forward. I don't know, Joe, if you had something to add to that.
No, nothing really. You know, when these vaccines first came out, first of all, historically, we have never had to do anything like this at all in the history of our country. These vaccines, even though mRNA vaccines have been used since the 1990s, I know initially on there were supply chain issues in making the vaccines. A lot of the manufacturing supply chain issues have been worked out, and like Andy said, moving forward, we are going to have more vaccines. Pfizer, Moderna, J&J, Novavax, AstraZeneca, looking forward to the springtime. So the supply conversation is going to look much different once we hit late spring, summer.
I want to add one thing, and it goes back to the vaccine hesitancy question. I think what I've heard from some people, especially early on, was this idea that warp speed, Operation Warp Speed, as the federal government called it, meant that they skipped steps or went too fast. For those of you who don't have experience in research or in pharmaceuticals, there are multiple steps in the FDA process to be approved. And what they basically did is do multiple steps at the same time. So kind of toxicity testing, which is phase 1, and then clinical trials, kind of phase 2 and 3, were all done at the same time, as well as the federal government contracted with the manufacturers even before the FDA had approved the vaccines to actually allow them to start manufacturing. So it held the companies harmless if their vaccine didn't cross the finish line. They weren't out the money. So the fact that all those things were done at the same time is why we're sitting here March 3rd with almost 500,000 doses of vaccine coming into the state. I mean, that was unthinkable a year ago. So I don't know if others have a sense of warp speed, but I do hear that from people sometimes that that's why they're hesitant. And it's not that any steps were skipped, it's just they did them all in parallel.
A couple things, too, just to piggyback on that, too. mRNA vaccines have been used in clinical trials since the 1990s. Adenovirus vector vaccines have been around since the 1970s, and in fact, there is a newly approved Ebola vaccine that uses the same platform that Johnson & Johnson does, and that vaccine has been studied in pregnant women and other populations. So these technologies of mRNA vaccines and adenovirus vector vaccines, they're new to the public, but in the realm of clinical medicine and research, they've been around for a long time.
Speaking of things that keep people from getting the vaccine, Carol Looper was asked, can you speak a little bit about side effects, what to expect, why some people get them, why some people don't?
So the vaccine side effects, the fancy medical word for that is reactogenicity. And what that really means is your body is mounting an immune response. That's an expected reaction. We have data from clinical trials through the V-Safe app, which people participate in. We have data from over 2 million people. The most commonly reported side effect is injection site pain, followed by fatigue. Some people can have a fever. Some people will have a headache. Some people people will feel off kilter like they had the flu for a day or two. The symptoms go away. Other than that, the vaccines are very well tolerated. And we know that people who have previously have had COVID can have some of those immune response more so with the first dose. For people who have not previously had COVID, the first dose is well tolerated and they have more of those vaccine side effects after the second dose. And we also know too that those 65 and older don't have the same level of reactogenicity as those 65 and older. Now, also, too, we have to call out the fact to say that you cannot say the presence or absence of reactogenicity means you had a vaccine response or not. I know many people, and even in the studies, there are people who had no vaccine side effects at all who were reported in all age groups. So you can't use that as a marker to say, oh my gosh, I got my second dose and I felt nothing, so the vaccine didn't work for me. You can't say that. There are people who don't have side effects. We're all different. Our immune systems are all different.
I do know we found this week with the J&J vaccine coming on site, we did our first 5 yesterday as a dry run of pulling it out of the vial and so forth. We had no trouble finding people that wanted to get the J&J vaccine. We do think there are some people that are sitting on the sidelines and have been waiting for a single dose, whether they have transportation issues, whether they have mobility issues and how they get around, or maybe this issue of I didn't want to have the second dose, I have a slightly higher risk of some aches, pains, low-grade fever, and they want to get a single-dose vaccine. And I think that may help us in our percent of folks vaccinated in those high-risk groups.
So since you brought up the J&J vaccine, we had one question from Bill Lafayette asking, does this vaccine create the same level of immunity as the 2-shot vaccines? And then Eric Brown followed up, with regard to the Catholic Church's view on the J&J vaccine, has this decreased the number of people getting the shot who are Catholic, and would they have a choice when they show up?
So I'll take the first part, and I'll give you the second part. If that's okay. So the J&J vaccine is it's a one and done. That's very different. And just to recap too, this operationally is easier to get out there because you only have to keep it in the refrigerator. You don't have to defrost it. You don't have to reconstitute it. It already comes in a liquid form, unlike Pfizer. The J&J vaccine gives a great immune response. There's two parts of the immune system. There's the antibody response, then there's another part that we don't talk about enough called the T-cell response. The J&J vaccine trials show that the antibody titers continue to go up 7 to 8 weeks after being vaccinated. And when you look at the scientific data on the T-cell response, it's phenomenal. And again, it's hard you can't really compare one vaccine to another, but the J&J vaccine induces a fantastic immune response and both great antibody levels that continue to go high 7 weeks out and a very robust T-cell response.
Before we get into the Catholic Church issue, Mysheika, do you want to talk about the effectiveness percentages that people focus on?
Sure. So when you look at all three of the vaccines that we have available to us now, they are all equally effective at reducing hospitalizations and deaths. And I think Dr. Gastaldo mentioned that earlier. That's what we're most concerned about. Obviously, we don't want people to die from this virus, and we don't want people to be hospitalized. And so all three are equally effective at that. And so, yeah, you could look at, one is maybe 80% effective and one is 95% effective. But the other thing we have to realize is the Johnson & Johnson vaccine was also done more recently. The clinical trials were done more recently and were done in countries as well as the United States where we knew we had variants circulating. And so this is more real time in terms of what's circulating in our environment today than some of the mRNA vaccines like the Pfizer and the Moderna.
So I will take a shot at the first question. Is it impacting those who are of the Catholic faith? Is it impacting their decision to receive the J&J vaccine? Don't know the answer to that question yet because we've literally just received it. So we haven't really been able to put that in arms a whole lot yet. However, I can tell you that it's not going to change our stance. So our stance as a Catholic health system is we believe everyone should get whatever vaccine is available to them at the time that it's available to them. J&J will be one of the things that we offer. And if someone is Catholic and they wish to not use the J&J, we're going to do everything within our power to ensure that they have freedom of choice. So we will offer them the Pfizer and the Moderna and any other that is available should they not wish to take the J&J. We also want to make sure that we're offering a full complement of options for our patient population.
Kathy Fox asks, since it sounds like there will be plenty of doses for all adults to get vaccinated who want to, can our health system in Central Ohio handle that volume and get everyone vaccinated by May? And a similar question from Mindy Wright. For a while, states were left on their own with their local agencies to administer the vaccine. Other than facilitating the production, is the federal government helping Ohio?
Well, so I think the healthcare system that we have here in Franklin County, we're very fortunate. If you look at other large municipalities, to have 4 healthcare systems that work collectively with their local health department as well as with the state to get individuals taken care of, we're fortunate in that regard. I think if you talk to any of us up here as well as others in the community that are currently vaccine providers, they'll tell you that they have the capacity to do more, they just need more vaccine. So I'm very optimistic that with more vaccine coming to our state and our community, we will be able to get those who want to get vaccinated, vaccinated. The state has been a huge partner, not only to local health, but also to all of the hospitals, and asking and trying to help us get the resources we all need to get this vaccine into people's arms. The federal government is helping by giving us the vaccine. I mean, they are helping to produce the vaccine and delivering the vaccine to us. Keep in mind, none of us up here who are vaccine providers are paying for this vaccine. Now, it is our responsibility to get staff to help us provide the injections to individuals, and the state has also assisted with that. Just this week, we got 5 nurses from the state. The state has a contract with a nursing agency, and we got 5 nurses from the state to assist us with more of our vaccine work that we're doing at the fairgrounds. So I think we are prepared and we are ready. We just need more vaccine, and I think the state has been a great partner, as has the federal government.
I would add to that, too. I think the state has really attempted to scale up as the vaccine has scaled up. If you look a couple of weeks ago, there would have been about 700 sites in the state of Ohio where you could get the vaccine, and about 80 sites in Franklin County, where this week it's now up to 1,200 plus sites in the state of Ohio and over 100 sites in Franklin County. So at this point, retail pharmacies, especially the large chains, but as this week with J&J coming online, more independent pharmacies in smaller towns and communities around the state have gotten doses of the vaccine. Certainly health departments, hospitals, and I think the next step moving forward with more J&J doses will be physician offices where, as we've talked about, it's easier to store and easier to administer. So I think that the state is scaling up as the vaccine supply is scaling up.
Well,
I'll agree. One thing I do want to piggyback on are the retail pharmacists. Pharmacists are vaccine providers. They have been for years. A lot of people don't know about that, and they have really ramped up to feel a need to put vaccines into people's arms. For years, you can go to a retail pharmacist and get a flu shot or a pneumonia shot, and we're really leaning in on them. And places like Giant Eagle, Kroger, Myers are really stepping up and helping put vaccines into people's arms.
Well,
In addition to state, I know this is part of the state response, but also the National Guard has been very active and will continue to be. I know they're working with the federally qualified health centers, specifically at mass events. I think there's one scheduled even this weekend where the National Guard is going to be participating.
All right, from Roger Blackwell, he asks, if you've already had COVID, should you get your shot?
That's probably my most commonly asked questions. So the simple answer to that is yes. If you have previously had COVID, you should be vaccinated. Most people, not all, most people who do get COVID have a degree of immunity for a period of time that we really don't know how long it lasts. There are more and more cases bubbling up in the medical literature of people who have previously had COVID who get it again. There are variants that are out there that can spread much easier. The variants are likely to be more contagious. So the simple answer to that is if you have previously had COVID, as long as you are out of isolation, meaning you're no longer contagious, and you are feeling better from your COVID diagnosis, you can get vaccinated. Now, just to piggyback on what I said earlier before, when those people go to get vaccinated, they may have more of an immune response or reactogenicity, but they can be vaccinated and they should be vaccinated.
I think the only thing I would add to that is 2 things. First of all, hi, Professor Blackwell. Second of all is if you've gotten monoclonal antibody therapy, they do ask now that you wait up to 90 days to get your vaccine. So it's quite a little bit of a separate population than people who've just had COVID.
Well, I found today's forum very encouraging and very positive, and heard lots of good things. Excited to see a lot of motivated people. Hey, I am counting the days until my second shot on March 17, so I'm one of those folks. And two more successful vaccines in the wings. I like comments like community immunity. Maybe we should think about having a little competition with Columbus and Cleveland to see who gets the highest percentage of their population vaccinated as quickly. So thank you. Next week, we're going to also be looking at something that's a very important topic. We'll be exploring the digital divide part 2, which is a part of this conversation as well, as far as people having access to communication and information. So let's thank today's presenting sponsors, Nationwide Children's Hospital and OSU Wexner Medical Center. We also like to thank the Emergency Response Fund of the Columbus Foundation for presenting our live streaming with support from the Columbus Dispatch and PNC. Thanks again to all of you who bought virtual seats. We appreciate seeing you every week. You buy your seats. Thank you. And a special appreciation to our speakers. We obviously couldn't do these programs without your willingness to come and share the information. Dr. Mysheika Roberts, Dr. Joseph Gastaldo, Brian Pierson, Dr. Andrew Thomas, and our host, Greg Moody. Thank you all, and we look forward to having you back here online next week. Until then, make your appointment to get your vaccine, wear your mask, and be safe.